Good evening to you all. Welcome to tonight's webinar. I would like to welcome Dr. Hein van Wyk. As the invitation mentioned, he is a general ophthalmologist with a special interest in retinal surgery and all about the posterior segment. I want to apologize again for the massive amount of texts or messages that you received today, because I sent a group instead of a broadcast, but hopefully you did delete yourself from the group. Reminder that we will do all the questions and answers after the webinar. And Dr. Hein van Wyk, thank you very much. We're welcome to start with you.
Thank you, Louise. Just want to quickly call up my screen quickly. So then also from my side, thank you for spending time with me and with Visiomed tonight. I know it's valuable family time, and it's time you rather spend with something else than again talk about eyes and that. I hope that I'll be able to share some of my knowledge and that you guys will be able to take that back to your practices and get some benefit from this. So as Louisa said, we're going to talk about optical coherent tomography. Now, because it's such a wide field, I've decided tonight to only speak about the macular diseases that we often see in our practices. Now, as you're aware, optical coherent tomography is also used in other parts of the eye that we can image with this. We can image the cornea, like we have with the slide up to your left. We can image the anterior chamber. We can image the iris, the angle structures, and parts of the lens. Due to the iris being in the way, there is certain areas of the lens and ciliary body and zonules that we still cannot image. Even if we dilate a patient fully, we would still have problems imaging certain structures. Now, you can see on the next slide there in the middle, where the OCT was used to image some iris cysts. And then also for those of you that has machines also know that we can image the optic nerve, looking at a normal optic nerve, optic swelling, and a couple of other things. But as I mentioned, we're going to focus on the macula tonight. Before I started my practice, we only had the ability to do a fundus imaging and examine the retina with a direct and indirect ophthalmoscope and with the slit lamp. And with the slit lamp's design, the beam of light is supposed to help you to have a three-dimensional view or get a linear view of structures in the eye. But as we all know, if you don't have a well-dilated pupil and a patient that's really very patient, to evaluate certain structures in the retina with the slit is and always would be difficult. But with the advent of the OCTs, a whole new world opened, and it really revolutionized ophthalmology. So we could now have a linear scan, a side view of that same structure that we're looking at. And with modern technology, we can even create a three-dimensional model. And that gives us an idea of what is the pathology, how should we treat this patient, and what we should do with the follow-ups. So long gone is the day that we do a visual field and a couple of small tests. Now these days, we're using the OCTs, and what's wonderful of this is it's a non-invasive imaging test, and it uses light waves to take cross sections of the retina in our talk tonight. So again, just an image of the eye, saying again that anything that you could visualize, the OCT would be able to take pictures of. So of course, the cornea, the iris, parts of the lens, and the optic nerve and the macula. Now, there's quite a big drive that the latest machines are making larger cube scans at the back, of which the nerve and that is also imaged at the same time. But that's how the machines are developing. But there's still large areas like the ciliary body and vitreous base that's here, and areas of the ora serrata and beyond the equator that we still cannot image with optical coherent tomography. And just for you technical minded, this is just the little sketch that shows the principle of optical coherent tomography. So you've got a beam of light that's projected into the eye. There's linear scans coming back and a computer making sense of that and giving us images. For you that has attended some of my talks before, you know that I always put in some pathology, but we always look at the anatomy first. Now, in this case, because the macula is such a small structure, we're actually looking at the histology of the macula. And the retina has got 11 layers with the choroid going onto Bruch's membrane and creating 11 layers. So as you're aware, this is where the vitreous would sit. We've got the internal limiting membrane. We've got the nerve fiber layer, ganglion cell layer, internal plexiform, internal nuclear, and then the outer plexiform, outer nuclear. And it's normally this area here where the arrow is showing, or actually the laser pointer, where the photoreceptors sit on the retinal pigment epithelium. And if we look at the image here below, this is the type of scan that we would see with the OCT. So this is a typical OCT of a normal macula. Now, with the macula, we mean the whole area inside the ora serrata, including the fovea. And with the modern imaging, we can now see the vitreous face attached to the retina. We can even evaluate some vitreous features of floaters in that some gel sitting there. There's another piece of gel on the top there. In this slide, we also have a part of the nerve, but this is physically developed to evaluate the macula. The nerve would have a separate imaging to evaluate that. Also, there's a big scientific drive to look at the choroidal blood vessels here, because we think that some of the diseases like macular degeneration and other inherited choroiretinitis or chorioretinitis diseases are associated with abnormalities of the choroid that we might be able to pick up early and prevent disease. So I'm sure that you all that's attending the talk tonight has seen somewhere in your practice a patient with diabetes. It is an extremely common disease. And as statistics shows there, from 1980 to 2014, the amount of people worldwide jumped from 1.8 million to 4.22 million. Then the global prevalence of diabetes are currently currently standing at 8.5% in 2014, where before it was 4.7%. It's also showing that there's definitely an increase in the incidence of diabetes in the low to middle income countries. So for us living in a third world country, diabetes are going to become one of the main diseases that we will see, and we will have to follow up and treat. And even with modern science and modern treatment, we still have patients going blind from it. The other thing that I found interesting was that the World Health Organization said that in 2016, that diabetes was the 7th leading cause of death. So this is a patient that I saw at the beginning of the year. He's a 56-year-old patient, type 1 diabetic, so he is on insulin. He, in the beginning, acknowledged that he was not using his medication like he should, and I asked him to go and see his specialist physician, and after about a month and a half's treatment, his sugar control is better. But when we did the imaging, the complaint that he had lost vision in his right eye. There was no pain involved. It happened quite suddenly, could be explained. So on the fundus photo there's the optic nerve, there's blood that's situated on the nasal side, a little bit of new vascularization of the disc there, new vascularization of the retina. And as the vitreous, he got a vitreous detachment, as the vitreous face moved towards the lens, some of these blood vessels ruptured and it actually bled between his retina and the vitreous face. So the OCT that we're seeing there that's the inside of the vitreous, that's the vitreous face. All of this is blood. And due to the blood obscuring the laser light, we've got difficulty seeing the macular structures there. Now, with experience, we always have to examine the patient's other eye, because he said to me he had no problems in the other eye. And with further investigation, certainly he would have something there, and we can see that he's got blood hemorrhages, microaneurysms. I do not see any new vascularization of the disc or elsewhere, but he's got a start of macular edema. So there's a little red blood vessel there that's dilated and a small cystic area that's busy developing inside the macula there. So with this kind of patient, one can jump in and go and do a vitrectomy, or do a cataract and a vitrectomy, or just do a cataract. And the problem with that is that if you don't treat the process, the pathology that's happening at the back, it would be destroying the fundus. So you've got to get that under control first. So we've got two legs of treating this. So we've got the vascular route of patients getting anti-VEGF injections. So we either do Avastin, Lucentis, or Eylea, and it just depends on the medical insurance these days. They often ask us to do 3 Avastin injections, and if we can prove that there's no improvement, then we could go to a Lucentis or Eylea. So one would try and treat the vascular component to try and shrink these blood vessels and get some of the new vascularization to quiet down. If you get a good response on that, one can then decide you could do a YAG laser and actually punch a hole in that vitreous face, and the blood will then leak into the vitreous cavity away from the macula. The problem just there again is that it will still stay in the vitreous and it will still take time to absorb. You could also go and do argon laser, scattered peripheral laser, but again that most likely will cause macular edema. So in this case, as soon as I get the vascularization under control, I will be doing a vitrectomy, removing the blood, removing the vitreous that is pulling, and treating this focally with argon laser. Left eye would just be treated conservatively with follow-up, and if that macular edema gets worse, we would most likely do Avastin injections. You could then later on do scatter photoablation with the argon laser. I wouldn't do anything from a laser point of view or surgery to that macula. So these images that we've got there is, as the heading says, of macular edema that is due to diabetes. So as you can see a variety of different images and pictures that you would see. Now, very important is the longer that these patients have this macular edema, the more damage they will have. So that is subretinal fluid, intraretinal fluid. There's some intraretinal hemorrhages with those white spots that's there, and then also some blood clots that's inside these cystic spaces. These patients normally complain that their reading has decreased. They would normally have metamorphopsia, meaning that straight lines will be bent or curved, or they would say that they have micropsia, where images actually looks smaller in the eye that's got this edema. Now again, different ways of treating it. If I get a referral like this, I would like to treat them as soon as I can. I believe that the antivascular endothelial growth factor treatments are first line treatments. So we would normally do 2 or 3 Avastins. If it responds, we will carry on with that. If it doesn't respond, we will use a cortisone that we inject into the eye. And you can either use triamcinolone, or you could use a product called Ozurdex. The triamcinolone is a substance that normally stays in for about 4 to 6 weeks. So you have to do quite regular repeated injections, and it does cause a lot of floaters because it's like little balls that you inject into the eye that's got the cortisone in these little things, and as they absorb, the cortisone is liberated, whereas the Ozurdex is like a little capsule that's injected into the eye. So it's a single thing. It's normally out of the visual axis, and it stays in there for anything from 4 to 6 months. Good. So as you can see, the next one that we're going to talk about is epiretinal membranes. It is very common. So it affects 3.1% of people under the age of 60, 10% of persons between 60 and 69, with the highest incidence in the age group 70 to 79 at 14.4%. And that's quite a high percentage. And then beyond 80, it affects about 10.9% of our patients that we potentially might see. So the definition of an epiretinal membrane is a sheet of fibrous tissue that's developing on the surface of the retina. Now, due to it sitting on the surface, it has the potential of affecting that patient's sight. There's also different names for it. So often we call it a macular pucker, macular fibrosis. I haven't heard of surface wrinkling of the retinopathy, but most likely you'll see it in the literature, or a cellophane maculopathy. Now, again, the textbooks say that epiretinal membranes is often caused by vitreous detachments, but as you can see in the top slide there, this patient still has its vitreous attached to the fovea. So in this case, that linear vascular tissue that we're seeing there is not related to a vitreous detachment. In this case, the patient will have normal vision still, with most likely no metamorphopsia or micropsia. In this case, the patient's visual acuity will start dropping. It will drop to 0.8, 0.6. Certainly have metamorphopsia on an Amsler grid, or if you ask them looking at a straight line, they would definitely have symptoms. Quality of vision would be deteriorated. This patient might have very little symptoms with still good vision, because half of the macula with half of the fovea still seem to have a regular structure. In this case, if sending me some images to give them an evaluation and saying, how often do we have to see them, or when do we have to see them? I might say to this, to the individual, if the patient still has normal vision and no metamorphopsia, to repeat the scan in 3 to 6 months and give them an Amsler grid to do a home test. And if they start dropping vision, going down to 0.8, 0.7, 0.6, or having distortion on the Amsler grid that we will have with these, the patient must be evaluated. Good. Then the next one that we're going to talk about is vitreomacular traction syndrome. So as you're looking at these images, and you seeing more and more patients and testing them with your own OCTs, you might come across this very regularly, where the vitreous is attached to the fovea, and you can just see how it's lifting the edges of the inner foveal lining there. Again, this patient most likely will be asymptomatic. No changes on an Amsler grid and vision still 100%. If we go to this, I'll show you a little bit later, this could be classified as a stage 1A macular hole. Again, often the patients have very little symptoms, if any, with that. As soon as they start having the outer part of the retina and the photoreceptors distorted with the amount of traction, they will start having, again, smaller images, the micropsia, bent lines, the metamorphopsia, and their best corrected vision will deteriorate. Now, the vitreomacular traction that we talked about previously could lead to the following. So then a macular hole. So a macular hole is where the fovea has got a split from the inner segment to the outer segment of the retina, involving the photoreceptors. Now, in America, patients older than 55, there's a 0.33% incidence in patients in India was running at 0.17%, and in the Beijing study, the Chinese, 0.16%. And this is how the macular hole will evolve. So that is a normal OCT with the vitreous still attached to it. It doesn't seem to have any effect on the foveal pit there. That is, like I said to you earlier, that we see often the vitreous just starting to pull on the foveal pit there, but not having any effect on the outer part of the retina. It's then classified as a stage 1A macular hole. Stage 1B macular hole is actually where the outer part of the retina, the photoreceptors are split, but the inner part of the retina is still attached to each other. And both these, the 1A, 1B, can either end up as a lamellar macular hole that we will discuss a little bit later, or the vitreous can detach. And as you can see, there's actually there a tiny piece of internal limiting membrane that's been torn off, but the fovea is closed and there's no hole. There's definitely distortion looking at the photoreceptor line there, but it is a closed hole. So 1A, 1B, and in certain instances, even a stage 2 macular hole can by itself end up a closed retina without any surgery necessary. Stage 3 macular hole is where a full thickness part of the retina has been pulled off. So there you can see some retinal photoreceptors and ganglion cells that's there with a gap in the retina. So the light is focused on bare choroid and pigment epithelium. And of course, those patients would have a central scotoma, so they'll have some black or gray spot in the middle. Quality of vision will be severely affected, again, metamorphopsia and micropsia. And then a stage 4 macular hole is where the vitreous is pulling into the vitreous space closer to the lens and the retina is moving further apart. All of these patients, I think, is quite important to be referred so that the patients can be explained all of the above and have a regimen of regular follow-ups planned, and that they know what to expect. And if surgery is indicated in these last two, they already prepped for it, and they will accept it and not procrastinate on having the procedure. So this is one of the patients that I saw recently on the 7th of April. She's 72. She is deeply amblyopic in this eye. So she actually just came for her annual checkup, and with the examination, with the fundus examination, is really unremarkable. If one looks at that fovea there, it doesn't really seem to be abnormal. We do have these hard exudates here and some tortuous blood vessels, but just quickly looking at that image, you most likely would be, you know, if you miss a macular hole looking at that, I wouldn't be too cross, but if you do an OCT, you can see a stage 2 macular hole with the piece of retina still attached to one of the sides of the retina, but the other one freestanding. This is the type of patient that you could follow up, because that hole can close. But again, informing the patient from day one and giving them a proper plan of how you're going to follow them up is very important. Otherwise, they might disappear and never ever come back. And seeing that it's an amblyopic eye, she might not even notice anything there. Even if you give her an Amsler grid, she doesn't have good vision there to give you a decent follow-up. So I normally plan to scan these patients every 6 weeks. And if I find that that's going from a stage 2 to stage 3, immediately I go and operate them. This is the patient then that was referred to me on the 9th of April. Again, a lady, she's 61 with a stage 4 macular hole. On the fundus photo, you can see that that fovea is definitely irregular compared to the one that we had before. This is then the type of patient that would need surgery. So we do a pars plana vitrectomy. We remove the vitreous. We remove the internal limiting membrane. We flute out the fluid that is between those two ends, and we then put in C3F8 gas to tamponate, and the surface tension normally pushes those two ends together. Now, with the gas inside the eye, the patients have very little vision, and they need to understand that it will take anything from 6 to 12 weeks to have decent vision, and they also need to stay in Johannesburg and not change altitude, because due to the altitude change, the gas can expand. And I often find it difficult to understand that they've had some vision, now they've got no vision after the operation, but reassuring them that it will return, but it's just the gas that's doing that. Now, we all forget about a simple little test, Amsler grid test. I mean, it's a cheap little thing to have, and I think each one of you should have that on your tables when you examine a patient. I agree that some patients you can explain until you're blue in the face, and they just do not know what to do or what to tell you as they do this test. But again, yes, that is a normal Amsler grid test. This is an abnormal Amsler grid test. So for the patient that had the stage 2 macular hole, one would give an Amsler grid, say do a weekly test. If you think there's a change, let me know, and do, from my practice, we do 6 weekly OCTs. Now, this is also something that you will see on your OCTs. So this is a lamellar macular hole. Now, that means that the inner layers of the fovea is distorted, but the outer layers and the photoreceptor layer is still intact. So often these patients still have good vision, but they have some distortion on the Amsler grid. They definitely have decreased best corrected vision, but often not under 0.6 or 6.9. Now, there's two different types of lamellar macular holes that's been identified. So the one is called a tractional lamellar macular hole. That's where you've got an epiretinal membrane, that dark line sitting there, distorting the inner layers of the retina. And often this can be surgically corrected. You also then get a degenerative lamellar macular hole, where there's actually aging and cells dying and atrophying, but there's not something tractional causing it. And often if you go and operate this and you remove that dark little piece of epiretinal membrane there, or that patchy epiretinal membrane there, these two ends come down a tiny bit, but it never has normal anatomy. So often this will not be operated. So of course, no talk of the macula will be complete if we don't talk about macular degeneration. So globally, aged patients between 45 and 85, 8.7% of them will have age-related macular degeneration, of which people with European ancestry has got an 11.2% chance of developing macular degeneration, people with Asian ancestry, 6.8%, and then people from African ancestry has got a very small risk of developing macular degeneration. So again, we've got 3 OCTs here. So the top one, we can see that there's some drusen. So that is these elevated areas of fatty deposits that's underneath the retina there. This is atrophy. All of the retinal pigment epithelium and photoreceptors are gone there, and that's why with the OCT we have these white marks, and that's called hyperreflectivity. Again, patient with a vitreous detachment, large drusen, patient with geographic atrophy, all of that is gone, so there's hyperreflective areas with very little photoreceptors left. So that is the dry form of age-related macular degeneration. Then the wet form. So this is one of my patients that I've been seeing for a couple of years now. These are scans that was done last year. She's 76. This is her left eye. And of course, this patient complains of decreased quality of vision. Best corrected vision was only 0.1. She had a pigment epithelial defect, hard exudates, and this whole area of the macula looks mottled and pale. And on the OCT, she has intraretinal fluid with a lot of photoreceptor loss over there. This patient is treated with anti-VEGF injections, and what we're trying to do with that is to limit her scotoma, to try and make this scotoma as small as possible and try and get rid of as much fluid as we can. Unfortunately, we still have patients expecting that if we do 1 injection or 2 injections or 3 injections, that we're going to treat and we're going to cure them and they're going to have normal vision. And unfortunately, that is not macular degeneration. We still do not have something that would cure it. We certainly don't have something that will stop it, but we've got the treatment to slow down the process and buy some time. So this again is another patient. Again, in the middle of last year, we started with her treatment. This was her first session that we saw her. She's 78. It's her right eye. If you look at the fundus photo, you can just maybe see some retinal pigment epithelial changes there, and the retina just looks a little bit hazy on the fundus photo. And if you look at the OCT, she's got subretinal fluid. She's got a pigment epithelial defect with fluid underneath the RPE. And again, this is a patient with macular degeneration. The wet type treatment is anti-VEGF injections. Then a very interesting disease is central serous chororetinopathy. Now, we often see this young patients, they normally 30, 40, 50 years of age, and they normally type A personalities. They very stressed. They could also be low myopes, and we see it a little bit more in men than we do in ladies. And it can have different presentations on OCT. This is the classic presentation of a central serous. This is also classic, but they also have a small retinal pigment epithelial detachment there. And again, this is a patient that most likely has been treated, and the subretinal fluid is busy resolving, and there's a small amount left. Again, the longer that subretinal fluid is left, the worse the patient vision is going to be long term. So the current treatment for that is a drug called Inspra and anti-inflammatory drops. Very important is the patients need to look at their lifestyle. They need to try and get rid of their stress. And then if they take cortisone or steroids, that's often the reason for this, either nasal sprays, cortisone on their skin, bodybuilders that inject them cortisone, people with chronic back problems, autoimmune diseases. If they have these changes, those treating physicians that's giving them the cortisone better stop soon, otherwise we're going to lose this patient's sight. So they all have metamorphopsia, micropsia, decreased vision, poor best corrected sight. Now, with COVID starting last year, we all heard of a drug called plasmaquine. Now, plasmaquine has been around for a very, very long time. But, you know, in the news, everybody said, don't take it because it can cause eye damage. And yes, I agree with it. Plasmaquine can cause damage to the eye, but it's normally patients that's been on treatment for 3 years or longer. The dosage is normally about 200 milligrams per day. It's one little capsule, and that's 7 days a week. But often you'll see that doctors initially give the patients double dose, or the patients misunderstand and they take extra meds, and then they can develop maculopathy due to the toxicity. So on the autofluorescence, they have a bullseye maculopathy. So they've got these rings like you would see on a target, the bullseye. And if we look at the OCT, they still have a tiny amount of photoreceptors right in the fovea. But from here onwards to the sides, there's no more photoreceptors. So this patient has got massive, massive problems. And if you stop the plasmaquine when you see them like this, often the disease process will stop. There might be some cells here that's still alive, but might die as time goes on, but it most likely won't wipe the whole fovea. But I mean, this patient has lost more than 90% of their photoreceptors, and their quality of vision will be severely affected, and there's no treatment for this. The reason why I put this slide in is I recently got a patient where I was just shown the OCT. Now, this is the OCT on separate days. So that's the OCT that started and a couple of days later. So if we just focus on the OCT, that is the fovea, and of course the whole macular area. Here we can see that the macula is detached. Here the macula is detached and it's swollen. So if you just look at this, you might say, oh, the patient's got a retinal detachment, I need to go and operate it. But if you start examining the patient, you'll see that the optic nerve is severely swollen, and you've got these hemorrhages on the side there, and the blood vessels are congested, and this swelling increased from there to there. So this patient has got neuroretinitis and needs to be evaluated from a neurological point of view. And when you treat them neurologically, this most likely will resolve by itself. So honestly, no surgery for that patient, because you were going to just put petrol on fire there. So if we look at the previous thing that we had, if we look at this, we might say, okay, but that's neuroretinitis. But have a look at the slide. So there is the optic nerve. There it is. There's no swelling of the optic nerve, and there's definitely no connection between the nerve and the retina. This is something sitting on the patient's temporal and superior part. And the neurosensory retina is lifted up, there's fluid, and then intraretinal, there is also some macular edema. We are having a hyperreflective area here, but that's just an artifact created by the OCT. So it's actually a retinal detachment. And if we think three-dimensional, this part of the retina is coming towards us. And if I go and operate this patient, it's important to note that the vitreous is still attached to the retina. So this is going to be technically a very difficult procedure because I need to get the vitreous off first, and then I can attend to the detachment. So again, another slide of a patient with a retinal detachment, macula off. And then often I'm asked, you know, how important is a referral of a retinal detachment? Could you wait a day? Could you wait 2 days? Could you wait a week or whatever? And most of the vitreoretinal surgeons will say to you, if the patient's macula is still attached and they've got far on the periphery, they've got detachment, it's fine. Send them immediately because the macula is attached. That needs to be done sooner than later. If the macula is off, you've got time. But as we know, these photoreceptors, for every week that goes by, we lose 10% of their sight. So any retinal detachment patient, either with macula on or macula off, should be attended to sooner than later because their long-term prognosis is severely affected on when the macula either detached or when the retina detached. Something else I just also want you to have a look at is the scan itself. So just keep in mind that this scan that we're looking here is in that direction, in 90 degrees, is a linear scan from 12 to 6 o'clock. The previous one that we had was running from 3 to 9, so a horizontal scan. And often, if you were to do the scan in this direction, you will not have a detached retina. So it's important, again, not just to look at single linear scans, but examining the patient and confirming what you're seeing in the eye to what you're seeing on the OCT. Then our last slide that I've just put in here is about choroidal melanomas. We could also say choroidal nevi, but I've put in the melanomas because we often do fundus photos and we see this dark patch at the back of the eye. And we often wonder, is this a nevus or is this a melanoma? And again, I think if we have any pigmented lesion or any raised lesion in the eye, it should be referred to an ophthalmologist so that they take the responsibility of making the diagnosis and the follow-up. But just to give you an idea, choroidal melanomas is the most common primary malignant intraocular tumor. And it's also the second most common melanoma in the body. So first is the skin, then the eye, and then we could have under the nails, and we could have deep dermal and other places. But the eye is an extremely important you know, if you have a pigmented lesion there, rather refer it than leave it because we could end up with a disaster. So this patient had a OCT scan. So we had a choroidal lesion that is elevated. And then on one of the other scans, we have subretinal fluid. And also one of the tests that we do, so we do the fundus examination, OCT, and we do an ultrasound, a B scan, and it will show us the tumor there. And normally the tumor is dark inside, and that's very indicative of a choroidal melanoma. So I want to thank you for listening to me. I hope that I'm on time there. If there's any questions, you are welcome to forward it to us and we can try and answer them.
Thank you very much, Doctor. We have one question so far. You're welcome to ask any questions. If you're not asking, somebody else would love you to ask. The question that's here is, why does medical aids want to try Avastin 3 times and then Lucentis or Ilia?
So at this stage, it's all about cost effectiveness. So there's still a large patient base that will respond on the Avastin. So from a financial point of view, the drug, the Avastin, is about 650 Rand just for the drug, not for the procedure doing the jab. Whereas Eylea and Lucentis is over 8,000 Rand. So it's purely about money. So they will fund 3 Avastins. If you can show that it's not helping for your diabetics, your macular degeneration patients, then you're allowed to do a second-line drug.
Thank you. There's another one from Chantel. What is the criteria for removing an epiretinal membrane versus monitoring it?
Yeah, so there's a lot of different opinions about that. I'll give you mine, but there is some surgeons in Johannesburg that has other criteria. So I normally say if the patient has got metamorphopsia on their Amsler grid, that means that there is traction on the outer retina layer, the photoreceptors. So if there's metamorphopsia, best corrected vision goes down, it should be operated. And I normally use 0.6, so 6/9 vision with metamorphopsia. Those patients I operate. I know that there's a big drive that even if their vision is still good and you're finding an early membrane to remove it, there's some positives of that, but vitreoretinal surgery still are risky. You can get a retinal detachment by creating tears. You can actually induce a macular hole. You often have a cataract after the vitrectomy, then you have to sort that out again. You have a risk for endophthalmitis. So I would normally say 6/9 and metamorphopsia on the Amsler grid.
Thank you. Natalie, how long does it take for a macular hole to progress along the stages? Is there anything that we should advise the patient against to try to stop the progression?
Yeah, it's unfortunately like me telling how long a patient's got to live. Macular holes can go from a stage 1 to a stage 4 within 12 weeks, but it could also take 9 months before it gets to that point. So each person is different. From a lifestyle point of view, it's got nothing to do with computer work, nothing to do with exercise, nothing to do with diet. So it's not a physical problem, it is a mechanical problem with their vitreous being very tightly adhered to the macula, and as they get the vitreous detachment, as we all get it, as we looked at that statistics, there's a small amount that will tear and the others won't. And so I say when I diagnose it, 6 weekly OCT follow-ups and weekly Amsler grid test. And if they're not sure, I'd rather see them every week. But I would say it would not take longer than 9 months, and the shortest that I've seen is 3 months.
Thank you. What causes the epiretinal membrane?
We don't know. So if you read the textbooks, they say it's a vitreous detachment. I've just shown you on the first slide that we showed of a epiretinal membrane. That patient still had a vitreous that was attached. So that's not the cause. So there's other causes that they state in the literature. They say trauma, then uveitis or inflammatory process, but we're not exactly sure why that happens.
Thank you. Will macular holes sometimes only be seen on OCT and not on a fundus pic?
You can see it on the fundus. As I showed you the stage 4 macular hole, you could actually see the macular hole on the 2-dimensional photo. But if you use the slit lamp in that patient, you would see the defect. You would see the slit at the top and the bottom of the fovea, and as the hole is in the fovea, it just dives into there. So yes, you can, but it's normally a stage 4 and stage 3 that you will see. That's why I think that an Amsler grid is not a bad test to have. If you don't have an OCT, it's not a problem. It's just doing an Amsler grid test as a routine. And if you get an irregularity on that, rather refer it on just to make sure.
Thank you. Other than amstelgrit, any other screening test for MAD in the early stages for optometrists?
So if you don't have an amstelgrit, you can use a picture frame, door frame, grouting on the floor. You can say to them, if you look at the lines, the tiles on the floor, if you close the one eye, close the other, is there only any jagged lines? But that's a very rough kind of test. The best is to do a little amstelgrit test. Louise, I mean, we've got our own little booklets, myself and Jeetan. So if you need amstelgrits, I mean, please, you could just let us know and we can supply it to the optometrist that's in our area. It's a couple of cents.
Thank you. Can you discuss reticular pseudodrusen and your treatment protocol?
All right. So the thing with drusen is there's different types of drusen. So you get a hard drusen that's normally a well-defined small yellow pigmentation that's underneath the retina. Then you can get soft drusen or reticular drusen, and the edges of that drusen is not well defined, and it looks like just a piece of fat that was thrown onto the RPE cells there. Now, again there, any drusen has got the risk of progressing and developing into macular degeneration, but your soft drusens has got a higher risk. And even with the modern imaging that we have, it's sometimes difficult to evaluate how much soft drusen is there, or the amount of hard drusen that's there. Is this affecting the patient's vision or not? Only time will tell. So on the OCTs, you could see it, that it's got a more diffuse slope up and down, whereas the hard one, it looks like a little peak. I normally say, if there's drusen, refer the patient, and then the ophthalmologist can make the call on what the follow-up regimen will be. If they then say, listen, this is hard drusen, the optometrist can do the follow-up and maybe come and see us every 4 or 5 years, not a problem. Or no, you soft drusen, rather come and see us. Again, if there's drusen, we can't do much. We say that you've got an increased risk of developing macular degeneration if their vision is still normal. If they don't have metamorphopsia, I say to them, wear dark glasses when you're outdoors. So your 400 nanometers wavelength of blockers, and no nicotine smoke. So no passive or active smoking, and then also to use Ocuvite with lutein or any similar drug. It's sometimes not fair to tell a patient you've got macular degeneration, but they don't have any visual symptoms, and they might even pass away from something else before they've lost their sight. And you make them paranoid because you said to them, you're going to go blind, you've got macular degeneration. So I'd rather say to them, listen, you've got this drusen, you've got this percentage of risk. This is what you've got to do to try and slow down the process and bring them back on a regular base. But yes, soft drusen has got a higher risk of ending up with visual complaints due to macular degeneration, where your hard drusens has got less. There's also something called familial drusen. So you get patients where the fundus are just scattered with drusen, and it's a familial thing. They will never end up with visual disturbances because of that. Their family, if you scan their family from their mum or dad's side, they will be, most of them will have it. It's like a fingerprint or a facial feature, a lid that hangs, or a mole that some family members have, or a big nose like I've got. So that kind of situation, again, if you say to him, you got drusen, you've got macular degeneration, you're going to go blind, I don't think it's fair. See them, warn them, and follow them up and see what happens to their sight. If it deteriorates, it's macular degeneration. And also the use of cholesterol medication to try and resolve drusen. Cholesterol medication in itself has got a lot of side effects. It causes muscle cramps. It causes liver problems. Again, those patients should be seen by the eye specialist or specialist physician, and they may need to tell them the risks and the benefits, and the patients must take the call if they want to take cholesterol medications, but the verdict on that is still out.
Thank you. At what stage should we refer for macular degeneration?
Yeah, so again, there, I think if you see a patient that has got drusen in the macula where the fovea is involved, 5 drusen or more, that's the classification of macular degeneration or risk for macular degeneration. So if they've got 5 or more drusen on your fundus examination in the macular area of, and the fovea is involved, they need to be referred on. That ophthalmologist will then say to the patient, listen, this is hard drusen, soft drusen, familial drusen, whatever. This is the follow-up regimen. If they don't, then ask the ophthalmologist to give you a little bit of a feedback so that you have a plan forward if they don't have a plan.
Thanks. Is there any harm in optometrists prescribing Ocuvite?
No, I don't have a problem with that at all.
Then, sorry?
Sorry, optometrists are still seen as the primary physicians of ophthalmology. So there's a tremendous amount of patients that would go to the optometrist as a first line and would never get to me, even if they know that they've got something like drusen at the back of their eye. But if you can then say to the patient, please, you're a smoker, you need to stop. You're increasing your risk 3-fold to get macular degeneration. Or you're spending a lot of time outdoors, living in South Africa, we've got less ozone above our heads, we've got more radiation. You've got to wear dark glasses or have photochromic glasses or whatever. And here, use your Ocuvite or a similar product. I know that we're going to slow down the process there. So it does not have to come to us to prescribe. If you feel that you're concerned and the patient has got a high risk, tell them to use the Ocuvite, no problem.
Thanks. There's another question. Why do you prefer to use Avastin before laser treatment for DME?
Right, so if you start lasering that patient, you are not taking away the chemicals that is causing the new blood vessels. So with laser, you are killing retinal cells. The idea is as you kill the photoreceptors, that you're decreasing the demand of oxygen. So if there's 1,000 photoreceptors, there's billions, but say for instance 1,000, you are killing 100 of them, so you only have 900 asking for oxygen, so there will be less blood vessels. If you do not treat the VEGF that's in that eye, it's like putting petrol on fire. So that patient that I showed earlier that's got the new vascularization, you go and laser them and they immediately start pulling and getting a tabletop detraction. They get a retinal detachment due to traction, and you also cause macular edema. So I've had a couple of discussions with colleagues of mine that will send me patients that would start doing argon laser. It's not first-line treatment. First-line treatment is controlling the inflammatory process at the back of the eye. Vascular with the anti-VEGF and cortisone doing the inflammatory cascade. If you have it under control, 2 or 3 injections, then you can start lasering. Then the patients do well. But you cannot just go and laser. You cannot just go and do a vitrectomy. Cannot go and do a cataract. If you've got a patient with macular edema and you do cataract, they have a detached retina within 3 months. You destroy that eye. The chemical reaction that you create by doing that phaco or doing that vitrectomy or doing that laser is a disaster.
Thanks. Will Ocuvite help or harm wet AMD?
No. So I know that there's some of the ophthalmologists that will only use Ocuvite or anything similar. I mean, we're using Ocuvite as a trade name now, and they're saying that they only reserve that for patients with wet macular degeneration, but you use it for both. It can be used for dry or wet macular degeneration.
Thank you, Doctor. I don't see more questions. Let me just check. I think we've covered everything. So I think that will then conclude our webinar. I would just like to mention, for those who might not know, Dr. van Wyk practices in both Bryanston and in Honeydew. Bryanston is on William Nicol, very big street in Bryanston, just off Fourways, just off the N1. And then Honeydew is on the western side of Johannesburg in the Roodepoort area, just next to Roodepoort. And I just want to tell you also, Doctor is a very humble man. He actually, we're not allowed to talk about eye specialists or even orthopedic specialists because nobody can be a specialist on the body. So Dr. van Wyk is very correct by saying he's not a retinal specialist, but he did do the subspecialty. And there are actually, I don't know, many ophthalmologists who did the subspecialty who do practice as retinal specialists. Then I think I just want to check, there might be one or two more questions here. While I'm looking at them, I will send your certificates within the next 5 days or so. So please let me know if you haven't received anything. And let me just check here. Okay, there's just somebody that said it. Thank you. It was a very good lecture. Then there's another question. Is occupied only for AMD?
Yeah, I'm not aware of any other retinal processes that you can use it for. You can for patients with Stargardt's disease, that is macular degeneration of the young, but it's called Stargardt's disease. You could do that. Retinitis pigmentosa, you could use it. It can't do any harm, but it wasn't tested in any of those patients, not as far as I'm aware. It was specifically done for the macular degeneration patients, the only study that was done there.
Thank you. I think, let me just have a look here again. Yes, there are no more questions and lots of compliments. Thank you very much, Dr. van Wyk. And to all of you, have a lovely evening. Sleep well. We'll let you know when the next webinar comes up. Bye-bye.
Thanks, Louise. Bye-bye.